Usually when we talk about getting a medical diagnosis, there's this expectation of precision. It feels like engineering, right?
Yeah, completely. Like a mechanic looking at a car engine.
Exactly. You fall off a bike, your arm hurts, you get an X-ray, and boom, that jagged white line shows up on the film.
Yeah.
The doctor points to it and says, there is your problem. It's a clean binary system, broken or not broken.
Right. It's a very comforting way to view health, honestly. We have this really strong psychological preference for things that are visible, things we can categorize and just immediately solve.
Yeah. The mechanical failures of the body are straightforward, but the moment you step out of orthopedics and step into the world of human metabolism, that expectation of a clean, visible break just completely falls apart.
Oh, it shatters. The diagnostic landscape gets incredibly murky.
It really does. And today, we are taking a deep dive into something that operates entirely in that murkiness. We are looking at this tiny gland, literally the size of a grain of rice, that acts as this, silent thief inside the human body.
It's a great way to put it, a silent thief.
Yeah, because over the course of years or even decades, this little gland can quietly pull the calcium right out of your skeletal system, just thinning out your bones, and then carelessly leaving that calcium behind to form stones in your kidneys.
And it does all of this operating in broad daylight, too,
Hmm.
right under the nose of your immune system and all your body's normal regulatory checks.
Which is terrifying.
Well, yeah, what makes this physiological heist so compelling from a medical standpoint is that it frequently happens without triggering a single physical alarm bell. You, as the patient, might feel absolutely nothing.
Wow.
Yeah, you could be walking around right now with this happening and just have no idea.
So to figure out how this silent process works and, more importantly, how modern medicine has figured out how to stop it, we are analyzing a massive new medical consensus document today.
Right, the new guidelines.
Yeah. Our source material is the Evaluation and Management of Primary Hyperparathyroidism, specifically the summary statement and guidelines from the Fifth International Workshop.
And I just want to jump in and say, the scale of this document is difficult to overstate. In the medical community, a consensus guideline from an international workshop is basically the gold standard of care.
Right. We're talking about a lot of brain power here.
Exactly. This is an assembly of over 50 global experts. We are talking about the top endocrinologists, endocrine surgeons, and bone metabolism researchers in the entire world.
And they basically locked themselves in a room to update the rules on this disease for the first time since, 2014?
Yeah, 2014.
Mm.
They convened to review a mountain of new research. Long-term randomized controlled trials, epidemiological data, all of it to fundamentally rewrite the playbook.
So our mission for this deep dive is to decode this incredibly dense, peer-reviewed medical manifesto into something you can actually use. We're going to explore how your body regulates a vital mineral, what happens at a cellular level when that internal regulation breaks down, and how doctors fix it today.
Because understanding this has really highly practical implications for anyone listening.
It really does. Look, even if you have never heard of primary hyperparathyroidism, or PHPT as we'll call it for short, you or someone in your family probably gets a routine metabolic blood panel done at an annual physical, right?
Most people do, yeah.
So understanding the biological ballet happening behind those numbers and learning how a perfectly normal-looking lab result can sometimes obscure a stealthy metabolic condition, that's just incredibly empowering.
Absolutely. It's about knowing what is happening in your own bloodstream so you can ask your doctor better questions.
Right. When you understand the mechanisms behind the numbers, you transform from a passive recipient of a lab report into an active participant in your healthcare.
I love that. So to really understand PHPT, we first have to establish the baseline of how your body manages calcium under ideal circumstances.
Okay, let's unpack this. Let's start with the terminology. Primary implies that the root cause of the problem is within the gland itself, rather than, a reaction to a problem somewhere else in the body.
Yeah.
And hyper, obviously, means overactive. So parathyroidism refers to the parathyroid glands. Now, if you touch the front of your neck, your thyroid gland is right there. The parathyroid glands are 4 tiny, separate nodules situated directly behind the thyroid.
Geographically, they are neighbors, sure, but functionally, they have almost nothing in common.
Right, really? I always assumed they work together.
A lot of people do. But the thyroid is responsible for your cellular metabolism, controlling how your body uses energy. The parathyroid glands, though, they are entirely dedicated to a single critical task. They are the absolute guardians of your serum calcium levels.
They defend your blood against low calcium.
Exactly. They are hyper-focused on that one job.
And calcium is much more than just like the building block of your skeleton, right? I mean, it's the signaling ion for your nervous system.
It is. It's how your muscles contract. Honestly, if your blood calcium drops too low, your heart literally cannot beat properly.
Wow, so the stakes are incredibly high.
That is the stakes of the game, yeah.
Yeah.
Your body prioritizes keeping blood calcium within this microscopic, tightly controlled range over almost everything else, including the structural integrity of your bones.
Wait, really? It'll sacrifice the bones for the blood?
Without hesitation. Under normal circumstances, if your serum calcium drops even a fraction of a millimeter below the optimal threshold, the parathyroid glands immediately sense that deficit, and they secrete a hormone called parathyroid hormone, or PTH.
Okay, so PTH is effectively the body's emergency calcium mobilization crew. When it gets released into the bloodstream, it has 3 distinct targets it goes after to raise that calcium level back up, right?
Yes, the first target is the skeletal system. Your bones are essentially a massive storage vault for calcium.
Right.
But when PTH reaches the bone tissue, it binds to receptors on cells called osteoblasts. And through a complex signaling pathway, it stimulates the activation of osteoclasts.
And osteoclasts are the cells that break down bone.
Exactly. They are the cells responsible for bone resorption. The osteoclasts secrete acids and enzymes that physically dissolve the bone matrix, releasing the stored calcium directly into the bloodstream.
Okay, well, that makes sense for a short-term emergency. If you are desperate for cash, you make a withdrawal from the vault.
Right, but you don't want to rely on that forever. The second target for PTH is the kidneys. Your kidneys are constantly filtering your blood, and normally a certain amount of calcium is filtered out and lost in your urine.
That's just normal waste disposal.
Yeah, but PTH acts on the renal tubules, the microscopic filtering tubes in the kidneys, and forces them to aggressively reabsorb that calcium. It pulls it back into the bloodstream instead of letting it escape.
Got it.
And at the exact same time, PTH instructs the kidneys to dump phosphate into the urine.
Wait, why phosphate? What does that have to do with calcium?
That's a great question. Calcium and phosphate have an inverse relationship in the blood. If they are both high at the same time, they can bind together and form solid crystals in your soft tissues.
Oh, yikes. That sounds bad.
It is highly dangerous. By forcing the kidneys to excrete phosphate, PTH ensures that the newly acquired calcium remains free and active in the blood.
That's brilliant. Okay, so the third target is the gastrointestinal tract. But from my understanding of the guidelines, PTH doesn't actually go to the gut directly.
No, it acts on the gut indirectly. It uses the kidneys as an intermediary.
How does that work?
Well, when PTH hits the kidneys, it upregulates an enzyme that converts inactive, circulating vitamin D into its highly active hormonal form. This is called calcitriol.
So that active vitamin D is basically the key that unlocks the gut.
Precisely. That active vitamin D travels down to your intestines and significantly increases the efficiency of calcium absorption from the food you are currently eating.
Wow, okay, so the PTH mobilization crew is working on 3 fronts simultaneously. They're liquidating assets from the bone vault, stopping losses at the kidney filter, and increasing revenue from the digestive tract.
That's a perfect summary. And once the blood calcium rises back to the optimal level, the parathyroid glands sense the change and shut off the PTH production.
And the mechanism that actually senses that change, the literal switch that turns the gland off, is called the calcium sensing receptor, or KSR.
Right. And the sensitivity of the KSR is just a marvel of cellular engineering. These receptors blanket the surface of the parathyroid cells.
They're just constantly monitoring.
They are. They constantly taste the extracellular fluid, sampling it for ionized calcium. The feedback loop is incredibly steep. A tiny increase in blood calcium binds to these receptors, sending an immediate signal that aggressively halts the release of PTH.
So in a healthy human, this system keeps the calcium level fluctuating by barely a few percentage points day in and day out.
Exactly.
It functions exactly like a thermostat in a house. You know, you set your living room thermostat to 70 degrees. When the house gets cold, the sensor registers the drop in temperature, turns on the furnace, and blasts heat.
Right.
And once the ambient temperature hits 70, the sensor registers it and shuts the furnace down. The parathyroid gland is the thermostat, calcium is the heat, and PTH is the furnace.
That analogy holds up perfectly when we look at what goes wrong in primary hyperparathyroidism. Because the fundamental problem in PHPT is a broken thermostat.
Okay.
The guidelines establish that in roughly 85% of cases, This disease is caused by a single benign parathyroid adenoma. Essentially, a non-cancerous tumor develops on just one of your 4 parathyroid glands.
And the guidelines say about 15% of the time it is multi-gland disease, where multiple glands become enlarged and overactive, right?
Yes, and less than 1% of the time it is actual parathyroid cancer.
Yeah.
But focusing on that common benign adenoma, the issue isn't just that the gland grew larger. The actual sensors are broken.
It is as if the sensor on your house thermostat is covered in a thick layer of dust.
What's fascinating here is what that dust actually is. The dust in this scenario represents a profound alteration at the cellular and genetic level. The cells comprising that benign adenoma undergo a process of clonal overgrowth.
Meaning they just multiply out of control.
Yes, and as these mutated cells multiply, they experience a physical reduction in the number of calcium-sensing receptors on their surface.
So there are simply fewer sensors available to taste the blood?
That is part of it. But the guidelines also detail significant epigenetic changes. The tumor alters the way it reads its own DNA. The gene responsible for building the KSR becomes heavily methylated.
Which means what, exactly?
Effectively suppresses the production of new receptors. The tissue physically loses its ability to receive the body's stop signals.
Oh, wow. So the thermostat is covered in dust, so it can't feel the heat in the room. It constantly assumes the house is freezing. It keeps blasting the furnace, pumping out massive amounts of PTH, even when the living room is 90 degrees.
Exactly.
In the body, that translates to the gland flooding the blood with PTH, even when the blood calcium is already dangerously high.
The tumor develops an abnormally high set point. Because it has so few functional receptors, it takes a massive toxic concentration of calcium in the blood to trigger enough of a signal to even slightly suppress the rogue tissue.
It's actively resisting regulation.
Yes, which means the emergency mobilization crew never clocks out. They are working 24 hours a day, 7 days a week.
Right.
They are endlessly dissolving the bone vault, endlessly forcing the kidneys to hoard calcium, and endlessly supercharging the gut.
The biological loop is totally shattered.
And that relentless biological drive is what leads to the physical devastation of the disease. But how that devastation actually looks when a patient walks into a clinic has undergone an astonishing transformation over the last several decades.
Yeah, let's talk about that, because the guidelines dedicate significant space to this historical evolution. And honestly, it reads less like a medical text and more like an epidemiological mystery.
It really does.
If you rewind the clock back to the 1930s or even up through the 1950s, primary hyperparathyroidism was not subtle. It was a severe, brutal disease.
The historical presentation was characterized by a medical mnemonic: bones, stones, abdominal groans, and psychic moans. But the most prominent features were definitely the bones and stones. Patients presented with an advanced end-stage skeletal condition known as osteoitis fibrosa cystica.
Which means the excess PTH had been driving the osteoclasts so hard for so long that the patient's skeletons were essentially being hollowed out from the inside.
They developed severe bone pain, massive structural deformities, and frequent fragility fractures. The bones would develop what are called brown tumors, which aren't actual neoplasms, but focal areas of bone destruction filled with fibrous tissue.
Their structural integrity was completely compromised.
Totally. And at the exact same time, the sheer volume of calcium being forced into the bloodstream eventually overwhelmed the kidney's ability to hold on to it.
So the calcium started spilling into the urine in massive quantities.
Yes, and this resulted in chronic, recurrent kidney stones. But worse than the stones was a condition called nephrocalcinosis, where the calcium actually precipitates and calcifies within the soft tissue of the kidney itself.
Ouch. That sounds permanent.
It is. It causes permanent scarring to the delicate filtration system, inevitably leading to chronic renal failure. The historical literature also mentions parathyrotoxic crises, sudden, life-threatening spikes in blood calcium that cause profound dehydration, coma, and carried a staggering mortality rate.
So in that era, if you had this disease, you knew it. You were visibly, agonizingly sick.
That was the reality of PHPT until the early 1970s. And then, a single technological invention completely altered the trajectory of the disease.
The automated blood chemistry analyzer.
Yes. Machines like the Technicon SMA 1260. They were introduced and rapidly adopted as standard practice in hospitals and clinics worldwide.
Because before that, doctors had to manually order individual chemical tests if they suspected a specific problem, right?
Exactly. It was slow and targeted. But with the auto-analyzer, a doctor could draw a single vial of blood, feed it into the machine, and receive a comprehensive panel of results, which included, crucially, a highly accurate measurement of serum calcium.
And the inclusion of calcium on that routine panel triggered a diagnostic revolution. I mean, suddenly doctors started noticing elevated calcium levels in patients who had just come in for a routine checkup.
Long before they ever developed bone pain or kidney stones, the reported incidence of primary hyperparathyroidism just skyrocketed.
The guidelines note that in the United States, the incidence shot up from a rare occurrence to a peak of 233 cases per 100,000 women. And it wasn't an environmental trigger causing a sudden epidemic of neck tumors, right?
No, not at all.
The disease had always been there, quietly working in the background. We just finally turned on the lights and saw it.
If we connect this to the bigger picture, the epidemiological curve is a perfect reflection of diagnostic technology. We shifted from diagnosing a disease characterized by end-stage anatomical deformities to diagnosing a biochemical imbalance in patients who often felt entirely healthy.
Which ushered in the modern era of asymptomatic PHPT.
Yes. The Fifth International Workshop Guidelines are very meticulous about how they define the disease today. Because we catch it so early now, the presentation is highly variable.
Right. The expert panel established 4 specific clinical phenotypes to categorize patients. Let's run through them.
The first category is symptomatic PHPT. This is the classical bones and stones presentation we just described. While it has become exceedingly rare in regions with routine health screening, it is still the predominant presentation in many developing nations where automated biochemical panels aren't widely accessible.
That implies the disease naturally progresses to that severe state if it is left completely unchecked.
Okay, so phenotype 2 is asymptomatic PHPT with target organ involvement, and phenotype 3 is asymptomatic PHPT without target organ involvement.
Correct.
Now wait, this terminology seems somewhat contradictory to me at first glance. If a patient has silent bone loss or an undiagnosed kidney stone, how can they be classified as asymptomatic? The body is clearly experiencing the symptoms of the calcium heist. It's a fair question, and it highlights a necessary semantic distinction in clinical medicine. In this specific framework, asymptomatic refers purely to the patient's subjective experience.
Oh, meaning how they feel.
Exactly. It means the patient did not initiate the medical encounter because of a physical complaint. They didn't go to the emergency room with the agonizing flank pain of a kidney stone, and they didn't consult an orthopedist for a fractured wrist.
They were just sitting in their primary care doctor's office for an annual physical, totally unaware.
Correct. The elevated calcium was discovered incidentally. Once that red flag is raised, the physician initiates a thorough investigation. If a subsequent bone density scan reveals osteoporosis, or renal ultrasound discovers a 2-millimeter stone resting quietly in the kidney, the patient is categorized as having target organ involvement.
So the biology of the disease hasn't fundamentally changed. It's still degrading tissue.
Yeah, our modern diagnostic lenses just allow us to intercept the damage before it breaches the threshold of physical pain.
Okay, that perfectly clarifies the difference between phenotypes 2 and 3. You can be blissfully unaware with organ damage, or blissfully unaware without organ damage yet. But the 4th phenotype listed in the guidelines is the one that really challenges the biological model, I think.
Ah, yes.
Phenotype 4 is normocalcemic PHPT, or NPHPT.
This is currently the most heavily debated and heavily researched variant in the field of endocrinology. Normocalcemic implies exactly what it sounds like. The patient's serum calcium levels are persistently normal. However, their parathyroid hormone levels are consistently elevated.
But wait, if the core problem is a broken thermostat blasting the furnace, how can the calcium level possibly be normal? The tumor is still pumping out the hormones, so the blood should be flooded.
That apparent contradiction is why it took so long to recognize this phenotype. It was only discovered in recent years when specialists treating patients with unexplained osteoporosis began checking PTH levels as part of a comprehensive bone health workup.
Okay.
They kept finding this specific cohort of patients: normal calcium, high PTH, and deteriorating bones.
How does the body maintain that normal calcium level while under the influence of an overactive gland?
The prevailing theory is that normocalcemic PHPT represents the earliest incipient phase of the disease. The parathyroid adenoma has formed and has begun secreting excess PTH. However, the patient's body is still mounting a successful compensation effort.
Like trying to fight back.
Yeah. The kidneys might be working in overdrive to excrete the extra calcium, or the skeletal vault might be resisting the PTH signals just enough to keep the serum levels balanced.
So the body is fighting a war of attrition to keep the blood calcium safe. But the collateral damage of that war is the bones getting slowly eroded by the constant high PTH.
Exactly. The debate among experts centers on the natural history of this phenotype. Longitudinal studies show that a certain percentage of these normocalcemic patients will eventually lose their compensatory mechanisms and progress to the classic hypercalcemic state.
The thermostat finally overwhelms the system.
Right. But another percentage of them just stay normocalcemic indefinitely.
Mm.
The high PTH continues to cause silent skeletal damage, but the blood calcium never spikes.
It makes you realize how difficult this must be to catch. If a standard blood panel shows normal calcium, the primary care doctor would never think to order a specific test for PTH. The thief remains completely invisible.
Which leads directly into the critical challenge for physicians today. When the disease can present with no symptoms, or even with completely normal routine lab results, diagnosing it requires rigorous, methodical detective work.
Here's where it gets really interesting. The guidelines dedicate a massive section to the diagnostic criteria and the differential diagnosis, because getting this wrong can lead to unnecessary, potentially dangerous surgeries.
Definitely.
The absolute baseline for a definitive biochemical diagnosis requires demonstrating an elevated serum calcium level alongside an elevated or inappropriately normal PTH level. And the physician must observe this on at least 2 separate occasions, a minimum of 2 weeks apart, right?
The requirement for 2 separate measurements is to rule out a transient spike caused by dehydration and acute illness, or just a lab error. But the most nuanced part of that diagnostic baseline is how the calcium is actually measured. The guidelines explicitly mandate that the total serum calcium must be adjusted for albumin.
Okay, this adjustment is a fascinating piece of physiology. When you look at the calcium circulating in your bloodstream, it isn't all acting the same way. Albumin is a protein produced by the liver, and in the context of calcium transport, you can think of albumin molecules as a fleet of taxicabs cruising through your blood vessels.
It's a highly accurate visualization for protein binding. I love that.
Roughly 50% of the calcium in your blood is dissolved directly in the fluid. That is the active, ionized, free-roaming calcium. It is the calcium that interacts with the receptors, signals the nerves, and causes the biological damage if there is too much of it.
Right.
The other 50% of the calcium is sitting inside those albumin taxicabs, just riding around the circulatory system in an inactive, bound state.
So when a standard laboratory runs a basic comprehensive metabolic panel, it measures the total calcium. It counts the free-roaming active calcium, and it counts the inactive calcium sitting inside the cabs, lumping them together into one number.
And if a patient is perfectly healthy, that total number is a fine representation. But what if the patient is older or malnourished or has liver disease and their body simply produces fewer albumin taxicabs?
If the albumin concentration drops, the total carrying capacity of the blood drops. There are fewer cabs, so there's less inactive calcium riding around.
Which means the total calcium number on the lab report will artificially drop. The
Great.
lab report might show a perfectly normal calcium level, but the active free-roaming calcium, the dangerous stuff that the broken parathyroid gland is pumping into the blood, could still be elevated to a highly toxic level.
Yes.
The lab report creates an illusion of health because of a protein deficiency.
That is exactly why endocrinologists must employ a mathematical correction formula. The standard clinical practice is to add 0.8 milligrams to the total calcium score for every 1 gram that the patient's albumin level falls below the normal baseline. This mathematical adjustment unmasks the hidden hypercalcemia.
And the guidelines also note that the absolute best way to avoid the taxicab math altogether is to just measure the ionized calcium directly.
Yes, if the laboratory possesses a highly calibrated ionized calcium analyzer, they can directly measure the free-roaming calcium, bypassing the protein-bound fraction entirely. This is particularly vital for diagnosing the stealthy normocalcemic variant.
Because if a physician relies solely on an uncorrected total calcium level, they will completely miss the active disease process.
They absolutely will.
So let's assume the detective work is done properly. The physician adjusts for albumin, runs the tests twice, and definitively proves the patient has high active calcium and high PTH. It seems like the investigation is over, but the guidelines warn that there is a lineup of biochemical mimics that have to be eliminated first.
This raises an important question, right? Because establishing the biochemical signature is only the first half of the diagnosis. The differential diagnosis ruling out every other condition that could cause that specific combination of high calcium and high PTH is arguably the most critical step before ever consulting a surgeon.
And the most insidious mimic on that list is a genetic condition called familial hypercalcemia, or FHH. Why is FHH considered such a massive trap for clinicians?
Because on a standard blood test, FHH looks virtually identical to primary hyperparathyroidism. A patient with FHH will present with elevated serum calcium and an elevated or inappropriately normal PTH.
Oh, okay.
If a doctor stops their investigation there, they will misdiagnose the patient and send them to a surgeon to have their parathyroid glands removed.
But the underlying mechanism of FHH is entirely different, isn't it? I mean, it isn't a benign tumor growing on a single gland.
Exactly. FHH is an inherited autosomal dominant genetic mutation. The mutation fundamentally alters the genetic code for the calcium-sensing receptor itself. But unlike PHPT, where the mutated receptors are confined to a single rogue tumor in the neck, the FHH mutation is systemic.
So it's everywhere.
Right. Every calcium-sensing receptor in the patient's entire body, in the parathyroid glands, in the brain, and crucially in the kidneys, is built with this faulty set point.
The patient's entire biological system has just agreed on a new, higher normal for calcium.
The body believes that this elevated calcium state is optimal. And because the system is in balance with itself, FHH does not cause the collateral damage we see in PHPT.
Oh, that's wild.
Yeah, the high calcium doesn't erode the bones, and it doesn't scar the kidneys. It's generally a completely benign, asymptomatic condition that requires absolutely no medical intervention.
Which means if a surgeon operates on an FHH patient, it is a disaster.
It is a surgical error of profound magnitude. Removing the parathyroid glands will not cure the hypercalcemia because the remaining glands and the kidneys will still operate on the mutated set point.
Wow.
The patient would be subjected to the inherent risks of general anesthesia and neck surgery, risking vocal cord damage and infection for zero clinical benefit. Parathyroidectomy in an FHH patient is strictly contraindicated.
So how does a physician differentiate between a single rogue tumor and a systemic genetic mutation if the blood tests look identical?
The key to unmasking FHH lies in the kidneys. The hallmark of the disease is right in its name, hypocalciuric, meaning exceptionally low calcium in the urine.
Ah.
In primary hyperparathyroidism, the kidneys are eventually overwhelmed by the toxic calcium load and begin spilling large amounts of it into the urine. In FHH, the mutated receptors in the kidneys aggressively reabsorb calcium, holding onto it tightly.
So the detective has to analyze the urine to solve the case.
The patient must complete a 24-hour urine collection. The physician then calculates the calcium to creatinine clearance ratio. This mathematical ratio compares the amount of calcium being excreted to the overall filtration rate of the kidney.
And what's the magic number?
If the resulting ratio is less than 0.01, it is a strong, definitive indicator that the kidneys are actively hoarding calcium, pointing directly to the genetic mutation of FHH. The scalpel is put away.
Got it. Aside from genetics, the detective also has to cross-examine the patient's medicine cabinet, because pharmacology can mimic the disease as well. The guidelines specifically call out lithium and thiazide diuretics.
Lithium is a primary medication used in the management of bipolar disorder. While its exact mechanism isn't completely mapped, clinical evidence shows that long-term lithium use alters the sensitivity of the calcium-sensing receptor on the parathyroid gland.
Shifting the set point higher, basically.
Right, and mimicking the dynamics of an adenoma. Thiazide diuretics, which are frequently prescribed for hypertension, act directly on the kidneys, enhancing calcium reabsorption and artificially elevating blood levels.
The guidelines suggest that if a patient is on these medications, the physician should try to temporarily transition them to a different drug, wait several months for the biological pathways to clear, and then retest the calcium and PTH to see if the thermostat resets itself.
Yes. And the final major mimic to rule out is secondary hyperparathyroidism. This occurs when the parathyroid glands are pumping out massive amounts of PTH, but they are doing so appropriately in desperate response to a legitimate systemic shortage of calcium.
Like a severe vitamin D deficiency.
Exactly.
Because if you don't have enough vitamin D, your gut can't absorb calcium from your food, your blood levels start to drop, and the parathyroid glands go into overdrive to compensate. So the physician has to check the patient's vitamin D levels, correct any deficiency with heavy supplementation, and see if the PTH calms down before diagnosing a primary tumor.
It is a rigorous process of elimination. But once FHH is ruled out, the medications are cleared, and the vitamin D levels are optimized, the biochemical diagnosis of primary hyperparathyroidism is locked in. The next phase of the clinical evaluation is assessing the magnitude of the damage. The evaluation battery. The physician needs to know exactly what the silent thief has been doing to the target organs over the years. The guidelines mandate a comprehensive audit of the kidneys and the skeletal system. For the renal system, the evaluation requires a precise measurement of the glomerular filtration rate, or creatinine clearance, to assess the overall functional capacity of the kidneys. But it also requires advanced imaging, typically a comprehensive renal ultrasound or a non-contrast CT scan of the abdomen.
Searching for nephrocalcinosis or silent, non-obstructing kidney stones resting in there.
Right. And the evaluation of the bones is where the imaging gets highly specialized. The standard protocol requires a DXA scan, which stands for Dual Energy X-ray Absorptiometry.
But the new guidelines highlight a very specific, almost fingerprint-like pattern of bone destruction associated with this disease that dictates exactly how the scan must be performed.
A standard osteoporosis screening usually just measures the bone density at the lumbar spine and the hip. But for a PHPT evaluation, the guidelines explicitly require a 3-site DXA scan. The critical third site is the distal 1/3 of the radius, which is the long bone in your forearm, specifically measured close to the wrist.
Why is the forearm such a critical measurement? Does the excess parathyroid hormone attack the wrist differently than the spine?
To understand that, we have to look at the structural architecture of the human skeleton. Your bones are comprised of 2 distinct types of tissue. Cortical bone is the dense, hard, compact outer shell that gives bones their rigidity.
Like the long bones in your arms and legs.
Yes. Trabecular bone, on the other hand, is the porous, spongy, honeycomb-like interior matrix that provides flexibility and shock absorption. The vertebrae in your spine are highly trabecular.
Okay, cortical is the hard shell, trabecular is the spongy interior. Got it.
Historically, epidemiological data in early DXA studies demonstrated a pronounced catabolic effect of PTH on cortical bone, while seemingly sparing, or in some cases even mildly protecting, trabecular bone.
Oh, interesting.
Consequently, a classic DXA scan of a PHPT patient will often reveal severe advanced osteoporosis at the distal radius, which is mostly cortical bone, while the lumbar spine, the spongy trabecular bone, might display a perfectly normal bone mineral density.
So the thief preferentially targets the dense outer shell. That seems like a solid, well-understood mechanism. But the guidelines indicate that this long-held medical consensus is currently being challenged by new imaging technology.
This is a prime example of how diagnostic resolution changes medical truth. While DXA scans are excellent at measuring overall bone mineral density, the sheer mass of the bone, they are 2-dimensional images. They cannot visualize the 3-dimensional microarchitecture of the bone tissue.
So what do they use instead?
To see that, researchers have begun utilizing a cutting-edge imaging tool called high-resolution peripheral quantitative computed tomography, or HRPQ-CT.
HRPQ-CT. That is a mouthful. But what does it actually allow doctors to see that a standard X-ray misses?
It effectively acts as a non-invasive virtual bone biopsy. It takes microscopic, high-resolution 3D images of the bone's internal structure. When researchers applied HRPQ-CT to patients with primary hyperparathyroidism, they made a startling discovery.
Which was?
The long-held belief that the disease spares the trabecular bone was entirely false.
The spongy interior wasn't safe after all.
Not at all. The HRPQ-CT images revealed profound degradation of the trabecular microarchitecture. The delicate honeycomb-like struts that give the spine its structural integrity were becoming physically thinner, more widely separated, and disconnected.
The bone was degrading from the inside out.
Exactly. The older, lower-resolution DXA scans simply lack the fidelity to capture this microscopic structural failure.
So the biological reality of the disease hadn't changed at all. We just finally invented a lens powerful enough to see the trabecular damage. However, the guidelines acknowledge that because HRPQ-CT is largely confined to advanced research institutions, and isn't available in standard clinics, the traditional 3-site DXA scan remains the pragmatic, global gold standard for initial evaluation.
We must rely on the best diagnostic tools that are widely accessible to clinicians. But this tension between what we can easily measure and what the patient actually experiences brings us to one of the most fiercely debated sections of the entire 5th International Workshop Guidelines.
The controversy over non-classical symptoms. Because while the global experts have absolute unshakable consensus regarding the damage to the bones and the kidneys, they enter into a profound intellectual and clinical wrestling match when it comes to the brain and the cardiovascular system.
The non-classical manifestations represent a highly fraught intersection of patient experience and evidence-based medicine. Patients diagnosed with PHPT frequently report a constellation of vague, subjective, yet intensely debilitating symptoms.
Like what?
They describe a profound, pervasive fatigue that doesn't resolve with rest. They report clinically significant depression, heightened anxiety, and a generally diminished quality of life. The most common complaint is a cognitive dampening frequently referred to as brain fog. They feel as though their executive function and memory are permanently clouded.
Well, from a purely mechanistic standpoint, that makes intuitive sense, doesn't it? I mean, calcium is the primary signaling ion for neurons in the brain and for electrical conductivity in the heart. If a tumor is flooding the bloodstream with toxic levels of calcium, it seems biologically obvious that it would disrupt neurological processing and cardiovascular function.
The biological plausibility is certainly there, which makes the panel's conclusion so jarring to many outside observers. The Fifth International Workshop Guidelines take a remarkably hard line on this issue.
What do they say?
They explicitly state that routine clinical evaluation for these neurocognitive and cardiovascular manifestations is not supported by the current data. Most crucially, they mandate that a surgeon cannot recommend a parathyroidectomy solely for the purpose of alleviating these specific non-classical symptoms.
I have to strongly push back on behalf of the patients here because there is a glaring disconnect. If you read the clinical surgical literature, endocrine surgeons frequently note a powerful association between this disease and severe psychological symptoms.
They do.
They report countless cases where a deeply depressed, cognitively impaired patient undergoes surgery, and while they are waking up in the recovery room, they tell the surgeon, the fog has lifted. I feel like myself for the first time in years. If a patient feels terrible and removing the tumor makes them feel better, isn't it overly rigid or even dismissive for a panel of experts to say, sorry, the guidelines say the evidence isn't there, simply because brain fog isn't as easy to quantify as a kidney stone?
That is a completely valid and necessary challenge. It goes to the very core of how modern medical guidelines are constructed. It is vital to understand that the experts on this panel are not dismissing the reality of the patient's suffering, nor are they calling the surgeons liars.
Then what are they doing?
They are enforcing the highest standard of scientific proof, the distinction between observational correlation and randomized controlled causation.
Explain that distinction in the context of brain fog.
Observational correlation is exactly what those surgeons are reporting. A patient has PHPT and severe depression. The surgeon removes the adenoma. The depression lifts. That is a highly compelling narrative anecdote. But from a purely scientific standpoint, you cannot definitively prove that the elevated calcium caused the depression.
What else could have caused it?
It could be the immense psychological burden and anxiety of living with an undiagnosed chronic illness. It could be poor sleep quality resulting from the condition. Or, crucially, the immediate relief felt in the recovery room could be a profound placebo effect. The intense psychological release of having finally undergone a definitive medical intervention.
Right. Without a control group, observational data cannot isolate the chemical cause from the psychological context. So how do you isolate it? How do you prove causation?
You must conduct a randomized controlled trial, or an RCT. You take a large cohort of patients, say 100 people who all have asymptomatic PHPT and all report severe brain fog. You randomly assign 50 of them to undergo the parathyroidectomy. The other 50 are assigned to a control group that receives active medical monitoring but no surgery.
Okay.
You then follow both groups for years, assessing their cognitive function using validated objective psychiatric scoring tools.
And what did the RCTs actually show when they did that?
The guidelines heavily weigh the results of several recent robust RCTs, including a landmark 10-year study. The data revealed that when subjected to rigorous long-term tracking, there was absolutely no consistent, statistically significant difference in the reversibility of neurocognitive symptoms between the group that had the surgery and the group that did not.
Oh, wow. Over a decade, the surgical intervention did not reliably cure the brain fog any better than observation.
That is a stunning result, but yes, it means the surgical anecdotes, while true for some individuals, don't hold up across a massive population. The guideline panel utilizes an analytical framework known as the GRADE methodology. It is an incredibly strict system for evaluating the quality of evidence before making clinical recommendations.
Okay, so if the highest quality evidence fails to demonstrate that surgery reliably resolves a symptom,
The panel cannot ethically endorse that symptom as a primary surgical indication.
because surgery is not a neutral intervention, every time someone goes to sleep under general anesthesia, there's a risk.
Yes, exactly. The central tenet of medical ethics is non-maleficence, do no harm. A surgeon operates in a complex anatomical space in the neck. There are inherent risks of permanent vocal cord paralysis from damaging the recurrent laryngeal nerve, risks of catastrophic postoperative bleeding, and risks of severe hypocalcemia if the remaining healthy glands fail to wake up.
If a patient's bones are visibly hollowing out on a DXA scan, the risk of a broken spine far outweighs the risk of the surgery. the benefit is proven.
But if a patient's only manifestation is subjective fatigue or depression, and the highest level data says surgery might not actually fix it, a physician cannot justify exposing that patient to the risks of a neck exploration based on a false hope.
Yeah, that makes sense. The guidelines are designed to protect patients from undergoing invasive procedures that lack a proven probability of success, which sets the stage for the most consequential decision matrix in the entire document. We know what the disease is, we know how to diagnose it, and we know what evidence is required to act. That brings us to the ultimate clinical crossroads. To cut or not to cut. The surgical guidelines. So what does this all mean? The definitive treatment for primary hyperparathyroidism is a parathyroidectomy, the surgical excision of the hyperactive tissue.
And the success rate for this procedure, when deemed appropriate, is remarkably high. The guidelines report a 97.8% biochemical cure rate, provided the procedure is performed by an experienced endocrine surgeon.
And the caveat of the experienced surgeon is paramount. The guidelines specifically define this as a high-volume surgeon who performs more than 50 parathyroidectomies annually.
The anatomy of the neck is highly variable, and these adenomas can be incredibly small. Sometimes they're hidden deep in the chest or behind the esophagus. This is not a procedure suited for a general surgeon who only encounters it once or twice a year.
Okay, so for the first category of patients, those categorized as symptomatic, the decision tree is very short. If a patient presents with the classic bones and stones, surgery is universally recommended unless they have severe comorbidities like advanced heart failure that make anesthesia a fatal risk.
The medical consensus there is absolute. The true complexity and the core purpose of these updated guidelines lies in determining the surgical threshold for the massive population of asymptomatic patients.
When do you intervene on a disease that the patient cannot feel?
The Fifth International Workshop established 4 absolute objective criteria for asymptomatic patients. If a patient meets even a single one of these 4 metrics, the recommendation definitively shifts from active monitoring to surgical intervention.
Let's analyze these tipping points. The first metric is the calcium threshold.
Surgery is recommended if the patient's serum calcium concentration exceeds 1 milligram per deciliter or 0.25 millimoles per liter above the upper limit of the normal laboratory reference range.
Why that specific threshold? Why not wait until it gets even higher?
Decades of longitudinal data indicate that once the serum calcium breaches that specific 1 milligram per deciliter buffer, the systemic risk profile alters dramatically. The probability of the patient suffering a sudden, life-threatening hypercalcemic crisis increases exponentially.
And that can lead to cardiac arrhythmias, right?
Yes, and acute renal failure. Furthermore, at that concentration, the rate of accelerated bone turnover becomes profoundly destructive. It is the biochemical tipping point where the risks of inaction far outweigh the risks of surgery.
The body can no longer safely compensate. Got it. The second criterion focuses on skeletal involvement.
If the evaluation reveals a DXAT score of -2.5 or lower at the lumbar spine, total hip, femoral neck, or distal radius, surgery is indicated. A T-score of -2.5 is the clinical definition of osteoporosis. Alternatively, if a vertebral X-ray imaging discovers a silent asymptomatic fragility fracture in the spine, surgery is immediately recommended.
The logic there is straightforward. The silent thief has successfully broken into the vault and caused structural failure. You must eliminate the thief to stop the bleeding, regardless of how the patient feels.
Right.
The third criterion examines renal involvement, and this is where the panel made some significant updates.
Renal impairment is a critical trigger. If the patient's creatinine clearance, the measure of their overall kidney filtration efficiency, drops below 60 milliliters per minute, surgery is required. Similarly, if renal imaging detects a silent kidney stone or the presence of nephrocalcinosis, intervention is necessary.
But the major update in these new guidelines concerns the 24-hour urine calcium excretion threshold, right? They lowered the threshold for what constitutes dangerous hypercalciuria.
They did. The panel recognized that sustained high-volume calcium transit through the delicate nephrons causes microscopic scarring and progressive functional decline, even if a visible stone never forms.
So what's the new limit?
If the 24-hour urine collection reveals calcium excretion exceeding 250 milligrams per day for women or 300 milligrams per day for men, surgery is recommended. The sheer volume of calcium is structurally toxic to the renal tubules.
So the first 3 criteria measure the breaking point of the blood, the bones, and the kidneys. But the fourth criterion is entirely independent of any lab test or imaging scan. It is strictly demographic. Surgery is universally recommended for any patient under the age of 50.
This one requires some explanation.
Yeah, please. Imagine a 48-year-old patient. Their calcium is only marginally elevated, staying safely below that 1 milligram threshold. Their bone density is perfectly normal, and their kidneys are functioning flawlessly. Why does the panel mandate surgery for a seemingly healthy patient simply because of their birth year?
It is entirely a function of cumulative exposure risk. Primary hyperparathyroidism is a relentlessly progressive disease. It does not spontaneously resolve. If a patient is diagnosed at age 48 and the physician chooses active monitoring over surgery, that patient faces a statistical inevitability.
That over the next 30 to 40 years, it'll catch up with them.
Exactly. The cumulative daily toll of that elevated PTH guarantees that they will eventually develop osteoporosis, renal impairment, or experience a hypercalcemic crisis.
The timeline is just too long for the body to hold out.
Right. It is profoundly safer and vastly more cost-effective for the healthcare system to perform a localized parathyroidectomy on a healthy 48-year-old than it is to wait 3 decades and attempt to surgically manage a frail 78-year-old whose skeletal architecture has already been permanently compromised. Age under 50 is a surrogate marker for lifetime exposure risk.
Okay, so once the decision to operate is finalized, the logistical planning of the surgery comes into play. In the past, surgeons had to explore the whole neck, right? They had to make a large incision and physically inspect all 4 glands. But now we have preoperative imaging, 4D CT, sesame B scans, ultrasound. Does that mean imaging is used to diagnose the disease? If a doctor suspects PHPT, do they order a scan to prove the tumor exists?
This is a point of absolute uncompromising emphasis in the guidelines. Preoperative imaging is never used to establish the diagnosis of primary hyperparathyroidism. The diagnosis is derived exclusively from the biochemical evidence, the blood and urine tests.
Why is the panel so rigid about separating the imaging from the diagnosis?
Because relying on imaging for diagnosis introduces an unacceptable rate of dangerous false negatives. Parathyroid adenomas can be microscopically small and highly variable in their cellular density.
So a scan might just miss it.
Exactly. If a physician orders a neck ultrasound on a patient with elevated calcium and the ultrasound fails to detect a tumor, the physician might erroneously conclude the patient does not have the disease. The patient is sent home and their bones continue to deteriorate. Conversely, the scans frequently identify benign, non-functioning thyroid nodules that look suspicious but have absolutely no endocrine activity, potentially leading to unnecessary surgical exploration.
If the scans aren't diagnostic, what is their clinical utility?
They function exclusively as a surgical roadmap. They're deployed only after the biochemical diagnosis is unequivocally confirmed.
Ah, okay.
Once the blood tests prove beyond a shadow of a doubt that the thief is inside the house, the imaging studies act as the architectural floor plan, showing the surgeon exactly which room the thief is hiding in.
And having that precise roadmap enables a completely different surgical approach, right? Minimally invasive parathyroidectomy, or MIP.
Yes. If a concordant sesame and ultrasound clearly localize a single adenoma on the lower right parathyroid gland, the surgeon does not need to explore the entire neck. They can make a microscopic, targeted incision directly over that specific gland, extract the tumor, and complete the procedure in a fraction of the time.
Dramatically reducing the surgical trauma and recovery period, but the human body is unpredictable. What if the imaging was slightly off? Or what if the patient actually has multi-gland disease? And there is a second hyperactive tumor hiding somewhere that the scan missed. How does a surgeon know, with absolute certainty, that they actually cured the patient before they closed the incision?
They rely on one of the most elegant applications of physiological physics in modern surgery, intraoperative PTH monitoring, or IOPTH. This technique exploits the remarkably short biological lifespan of the parathyroid hormone.
Detail how that works in the operating room.
Once released into the bloodstream, a PTH molecule has a half-life of roughly 3 to 5 minutes. It is cleared from circulation incredibly rapidly.
Wow, that is fast.
The surgical protocol leverages this speed. While the patient is anesthetized on the table, the anesthesiologist draws a baseline blood sample to measure the elevated PTH level. The surgeon then navigates to the localized gland and excises the suspected adenoma.
The broken thermostat is physically removed from the system.
Precisely. The surgical team then waits exactly 10 minutes. Because the half-life of the hormone is so short, any PTH produced by that tumor should rapidly degrade. After 10 minutes, they draw a second blood sample and process it through a rapid immunoassay analyzer situated right inside the operating suite.
They are watching the biochemistry shift in real time. That's amazing.
If the rapid assay reveals that the PTH level has plummeted by more than 50% from the baseline and has settled into the normal reference range, The surgeon has immediate, definitive biochemical verification that the hyperactive tissue has been completely removed. The patient is cured and the incision is closed.
It is absolute, irrefutable precision medicine.
However, if the 10-minute draw shows that the PTH level remains persistently elevated, it signifies that another rogue gland is still active somewhere in the neck. The surgeon immediately pivots, extending the incision to perform a comprehensive bilateral exploration until the remaining diseased tissue is found and the chemical levels finally drop.
It's a phenomenal system. But this entire surgical protocol relies on the patient being a viable candidate for general anesthesia. What happens to the patient who meets the surgical criteria, say, their calcium is dangerously high, but they are 85 years old, suffer from severe congestive heart failure, and the anesthesiologist determines they would not survive the operation? Or what if a patient simply refuses neck surgery under any circumstances?
Right.
Are they condemned to suffer the progressive destruction of their bones and kidneys?
Absolutely not.
Yeah.
And that challenging clinical reality leads us into the complexities of medical management. While we cannot physically extract the broken thermostat, modern pharmacology provides mechanisms to chemically hack the system and mitigate the collateral damage.
It is crucial to emphasize the terminology here. This is medical management, not a medical cure.
That is a vital distinction. These pharmacological interventions do not heal the underlying disease or repair the mutated calcium-sensing receptors. The tumor will remain active. The medications simply construct chemical barricades to protect the target organs from the relentless assault of the excess PTH.
Let's examine how we protect the skeletal vault first. If the tumor is constantly screaming at the osteoclast to dissolve the bone matrix, how do we intervene to stop the structural collapse?
We utilize powerful anti-resorptive agents. The frontline treatments recommended by the guidelines are bisphosphonates, such as alendronate, or a targeted biologic therapy known as denosumab.
These are the standard therapeutic agents utilized globally for severe osteoporosis. How do they actually function within the bone architecture?
You can visualize these medications as applying a microscopic layer of Teflon over the entire skeletal matrix. Bisphosphonates aggressively bind to the hydroxyapatite crystals within the bone. When the osteoclasts, the demolition crew activated by the high PTH, attempt to attach to the bone and release their dissolving acids, they inevitably ingest the bisphosphonate.
And what happens then?
The medication effectively poisons the osteoclast, inducing cellular apoptosis or programmed cell death.
The demolition crew is eliminated upon contact.
Exactly. Denosumab operates via a different pathway, acting as an antibody that blocks the specific chemical signal required for osteoclasts to even form in the first place. But the end result is identical. The biological mechanism of bone resorption is completely paralyzed.
Wow.
Even though the parathyroid tumor is still flooding the blood with PTH, desperately signaling for a calcium withdrawal, the bones become deaf to the command. The clinical trial data presented in the guidelines demonstrates that utilizing these agents in PHPT patients profoundly increases bone mineral density, particularly in the highly vulnerable lumbar spine and femoral neck.
The structural integrity of the vault is secured, but there is a massive physiological catch to this strategy, isn't there?
There is a profound limitation. By successfully locking the vault and preventing the release of stored calcium, you are protecting the skeleton, but you are not addressing the fundamental dysfunction of the thermostat. The parathyroid tumor continues to pump out massive quantities of PTH.
And because the calcium is trapped in the bones, the serum calcium levels in the bloodstream remain dangerously elevated. The bisphosphonates save the bones, but they do absolutely nothing to lower the toxic calcium concentration in the blood, meaning the kidneys are still filtering a massive, scarring load of calcium every single day.
Precisely. Which necessitates a different pharmacological approach when the primary clinical concern is life-threatening hypercalcemia rather than skeletal fragility. If the bones are relatively stable, but the blood calcium is spiking dangerously high, we have to attempt to hack the thermostat itself.
How to do that?
For this, endocrinologists utilize medication called cinacalcet.
Cinacalcet belongs to a class of drugs known as calcimimetics. That name implies it is chemically mimicking the presence of calcium.
It is a remarkable piece of molecular engineering. Cinacalcet acts as an allosteric modulator. It travels through the bloodstream and binds directly to the mutated calcium-sensing receptors on the surface of the parathyroid tumor, the sensors we previously described as being covered in dust.
How does binding to a dusty sensor change anything?
When cinacalcet binds to the receptor, it physically alters the three-dimensional conformation of the protein structure. This structural twist suddenly renders the receptor hypersensitive to whatever ambient calcium is already present in the extracellular fluid.
It effectively tricks the broken thermostat into registering a massive, overwhelming heat wave.
Exactly. The tumor's cellular machinery is suddenly fooled into believing there is a catastrophic overabundance of calcium in the blood. In a desperate biological panic, the tumor aggressively slams the brakes, significantly downregulating its synthesis and secretion of PTH.
And then the levels drop.
As the PTH levels plummet, the excessive stimulation of the bones, kidneys, and gut ceases, and the blood calcium levels rapidly normalize into the safe reference range.
That is an incredibly elegant pharmacological solution. But adhering to the pattern of medical management, there must be a limitation here as well.
The limitation is the inverse of the bisphosphonates. While cinacalcet is highly effective at normalizing serum calcium and protecting the renal system from toxic overload, comprehensive clinical studies demonstrate that it has absolutely zero beneficial effect on bone mineral density. It does not reverse the skeletal degradation.
So the physician is faced with a fractured therapeutic landscape. You have antiresorptives that protect the vault but ignore the toxic blood, and you have calcimetics that detoxify the blood but ignore the crumbling vault. It seems obvious why not simply prescribe both simultaneously.
The panel acknowledges that combination therapy has been explored in small-scale clinical trials with varying degrees of success. However, it requires an incredibly complex, expensive, and difficult-to-balance daily regimen of powerful medications, each carrying its own profile of adverse side effects.
Which is why surgery is the gold standard.
Right. This inherent pharmacological fragmentation underscores why the guidelines so forcefully advocate for parathyroidectomy whenever feasible. Surgery is the singular intervention that definitively resolves both the skeletal and the biochemical crises simultaneously.
That dynamic between the drugs makes total mechanistic sense. But as I was reading through the nutritional guidelines for patients managing this disease without surgery, I encountered a directive that completely shattered my logical understanding of the disease. I have to push back hard on this.
Oh, I think I know what you're referring to.
Oh.
Proceed.
This is the most counterintuitive thing I've read in this entire document. If I am a patient and my physician informs me that I have a tumor flooding my blood with a highly toxic, tissue-damaging level of calcium, my absolute first visceral instinct is self-preservation. I am going to immediately cease consuming dairy, eliminate calcium-rich leafy greens from my diet, and violently dispose of any vitamin D supplements I own.
Right. That's
I want to starve my body of any external calcium sources to lower the blood concentration. But the guidelines printed in bold, definitive text explicitly instruct physicians to tell patients do not restrict dietary calcium, and they mandate that patients must supplement vitamin D to maintain serum levels above 30 nanograms per milliliter. From a logical standpoint, why on earth would you intentionally add more calcium and vitamin D into a biological system that is already choking on it?
It represents the most counterintuitive, almost paradoxical aspect of the entire disease profile. But when you unpack the underlying physiology, it serves as a terrifyingly beautiful demonstration of how the endocrine system's survival mechanisms can be weaponized against the host. Let's analyze the logic of the body's response.
Please, because the idea of feeding calcium to a hypercalcemic system feels like medical malpractice to a layperson.
Imagine the scenarios you just described. You have a rogue adenoma autonomously pumping out PTH, elevating your blood calcium. Acting on your intuition, you severely restrict your dietary calcium intake and you allow your vitamin D levels to plummet, effectively shutting down your gut's ability to absorb any new minerals.
Okay, the external supply lines are completely severed.
Your body is a highly integrated network. The healthy parathyroid glands and, critically, the tumor itself are constantly monitoring the systemic environment. When you sever those supply lines, the entire system senses a profound deficit originating from the gastrointestinal tract. The biological calculus changes instantly.
The body panics because it realizes no new resources are coming in to sustain the baseline.
Exactly. The body interprets this severe dietary restriction as an imminent threat of starvation. This triggers a massive compensatory response known as secondary hyperparathyroidism.
So the original disease is primary, and now you have induced a secondary wave on top of it.
You've poured gasoline on a biological fire. The starvation signal forces the 3 dormant healthy parathyroid glands to activate and begin pumping out PTH. Worse, it strongly stimulates the already overactive tumor, driving it into a state of hyperproliferation.
Oh, no.
The adenoma physically grows larger and exponentially increases its output of PTH, desperately trying to find calcium that no longer exists in your diet.
And because there is no calcium arriving from the gut, that supercharged wave of PTH only has one remaining target it can ravage to fulfill the body's perceived need: the skeletal vault.
The exponential spike in PTH will relentlessly strip mine your bones. Clinical observation proves that restricting dietary calcium and vitamin D in these patients actively accelerates severe bone destruction and paradoxically drives the disease into a far more aggressive destructive state.
That is genuinely staggering. The body's own innate defense mechanism weaponizes the disease, forcing it to consume the skeleton faster. Therefore, maintaining a normal dietary calcium intake roughly 1,000 to 1,200 milligrams daily and keeping vitamin D optimized isn't about feeding the disease. It is about keeping the system calm. It prevents the secondary starvation panic that triggers the ultimate destruction.
Precisely. It is a critical component of patient education. The physician must override the patient's logical but ultimately destructive instinct to restrict.
We have extensively mapped the biology, the complex diagnostic protocols, the strict surgical tipping points, and the paradoxes of medical management. Let's transition into the final segments of the guidelines. We need to address the special cases and the future of the field, because human biology rarely conforms perfectly to standardized algorithms.
The expert panel dedicated specific, highly detailed sections to vulnerable populations whose biology radically alters the standard approach. The most critical and inherently dangerous of these special cases is the intersection of primary hyperparathyroidism and pregnancy.
Navigating a severe metabolic disorder during gestation sounds incredibly complex, managing the competing biological needs of both the mother and the developing fetus.
It is a profound clinical challenge. While PHPT during pregnancy is statistically rare, it carries a severe risk profile. The physiology is fascinating and dangerous. A mother with uncontrolled severe PHPT maintains a highly elevated serum calcium concentration.
Okay.
That excess calcium freely crosses the placental barrier, creating a hypercalcemic environment for the developing fetus.
The fetus is essentially bathing in a toxic concentration of calcium.
And the fetal endocrine system reacts exactly as it is programmed to. The fetal parathyroid glands sense this massive overabundance of calcium crossing the placenta, and they conclude that their services are entirely unnecessary. To conserve energy, the fetal parathyroid glands aggressively suppress their own function and enter a state of deep dormancy.
They go to sleep because the mother is providing an overwhelming surplus, but that creates a catastrophic vulnerability at the moment of birth, when the infant is delivered and the umbilical cord is clamped.
The massive maternal supply line is instantly severed. The neonate is suddenly entirely dependent on its own endocrine system to manage calcium. But because the infant's parathyroid glands have been deeply suppressed for months, they cannot wake up fast enough to mobilize the necessary PTH.
Leaving the newborn with no way to defend its blood calcium levels.
Without immediate aggressive intervention, the neonate can suffer a profound, life-threatening crash in serum calcium, profound hypocalcemia within hours of birth, leading to severe neuromuscular irritability, seizures, and potentially fatal cardiac complications.
That is a terrifying scenario. How do the international guidelines recommend physicians navigate this minefield?
It requires extreme multidisciplinary coordination. Mild cases, where the mother's calcium is only marginally elevated, are managed with highly conservative measures, primarily aggressive intravenous hydration to help the mother's kidneys flush the excess calcium.
What about the medications?
Pharmacological interventions like bisphosphonates and denosumab are strictly, absolutely prohibited, as they readily cross the placenta and would systematically destroy the developing fetal skeleton.
But if the mother's disease is severe and the conservative measures fail to lower the calcium,
If the maternal calcium consistently exceeds 11 milligrams per deciliter, the risks of inaction surpass the risks of intervention, and the guidelines mandate parathyroidectomy.
performing neck surgery on a pregnant woman?
Yes, but the timing and execution are hyper-specialized. The surgery is strictly scheduled during the second trimester, minimizing the risk of anesthesia-induced teratogenesis in the first trimester and the risk of inducing preterm labor in the third. Furthermore, the standard preoperative imaging protocols are completely discarded.
Right, because of the radiation.
The surgeon cannot utilize 4D CT scans or radioactive sestamides scans due to the radiation exposure to the fetus. They must rely exclusively on high-resolution ultrasonography to map the neck. If the surgical intervention is deferred until after delivery, a specialized neonatology team must be present in the delivery room, on high alert to continuously monitor and intravenously support the newborn's calcium levels, minute by minute, until their dormant glands finally awaken.
It is a stark reminder of how a single elemental mineral dictates the fundamental processes of life and death. Moving from the complexities of gestation to the complexities of inheritance, the guidelines also vastly expanded their recommendations regarding genetic testing. We previously discussed the FHH mutation, but the panel suggests genetic evaluation for a much broader demographic of patients now.
The integration of clinical genetics is fundamentally revolutionizing endocrine surgery. The panel now strongly advocates for comprehensive genetic evaluation and counseling for any patient diagnosed with PHPT under the age of 30, any patient presenting with multi-gland disease, any patient diagnosed with the exceedingly rare parathyroid carcinoma, and any patient with a documented family history of syndromic endocrine diseases, such as multiple endocrine neoplasia type 1 or type 2.
Let's focus on MN1 and MEN2. These are the inherited genetic syndromes where the biological programming is corrupted across multiple systems, causing tumors to develop not just on the parathyroid glands, but simultaneously on the pancreas, the pituitary gland, and the adrenal glands.
Exactly. Identifying these specific genetic mutations prior to surgery fundamentally alters the entire operative strategy. If a surgeon operates on a patient assuming it is a standard sporadic single-gland adenoma, they might perform a minimally invasive removal of one enlarged gland and close the incision.
But if that patient actually carries the MEN1 genetic haplotype,
Then the remaining 3 healthy parathyroid glands are not actually healthy. They are genetically programmed with a biological ticking clock, destined to eventually undergo clonal overgrowth and become hyperactive tumors themselves. The minimally invasive surgery would be a failure.
so what do they do instead?
Knowing the MEN1 status beforehand dictates that the surgeon must perform a comprehensive bilateral neck exploration, usually removing 3.5 of the glands, or removing all 4 and autotransplanting a small fragment of tissue into the patient's forearm muscle to maintain baseline calcium control while allowing for easy future access.
It is the ultimate expression of personalized medicine, tailoring the surgical intervention not just to the visible tumor, but down to the exact molecular blueprint written in the patient's DNA. For the vast majority of patients who do not require such extreme measures and who enter the long-term medical monitoring phase we discussed earlier, what does their clinical life cycle actually look like?
It transitions into a state of highly regimented active surveillance.
Oh,
This is not passive observation. It is a meticulous tracking of the disease's progression. The guidelines mandate an annual biochemical evaluation in checking serum calcium, albumin, and 25-hydroxyvitamin D levels. They require an annual assessment of renal function via creatinine clearance to ensure the filtration system isn't deteriorating.
and the structural integrity of the vault must be verified.
Yes, a comprehensive 3-site DXA scan is required every 1 to 2 years to measure the trajectory of bone mineral density.
The physician is continuously tracking the movements of the silent thief, waiting to see if it breaches the defenses of the bones or the kidneys. If a routine DXA scan reveals that the T-score has finally dropped past that negative 2.5 osteoporosis threshold, or if a routine ultrasound detects the crystallization of a new kidney stone, the monitoring phase immediately terminates, and the recommendation pivots firmly to surgical extraction.
Precisely. The guidelines provide a rigid framework for action. Yet, despite the comprehensive nature of this document, the expert panel concludes with a surprisingly humble research agenda. They acknowledge that while this document represents the absolute pinnacle of current medical understanding, vast frontiers of human metabolism remain fundamentally mysterious.
The humility of the scientific method. They explicitly point out that one of the most confounding mysteries they face daily is the radical clinical variability between individual patients. You can have patient A, who develops a 2-centimeter parathyroid adenoma that completely devastates their kidneys, causing recurrent, agonizing stones, yet leaves their skeletal structure absolutely pristine.
And sitting in the very next examination room is patient B, who develops the exact same 2-centimeter parathyroid adenoma, pumping out the exact same elevated level of PTH. But patient B's kidneys function flawlessly, while the disease relentlessly hollows out their lumbar spine, leading to multiple vertebral fractures.
It is the exact same broken thermostat, producing the exact same biochemical error, yet it inflicts entirely divergent patterns of collateral damage.
Yes, and the investigative frontier they are prioritizing to solve this enigma isn't exclusively focused on the genetics of the tumor itself. They are actively turning their attention toward the intricacies of the human microbiome and broader metabolomics.
The gut bacteria. We always end up back at the microbiome.
There is highly compelling emerging research investigating whether the specific, individualized colonies of bacteria residing in a patient's gastrointestinal tract fundamentally influence the downstream metabolic pathways of parathyroid hormone. Do specific bacterial strains alter the way the gut absorbs calcium? Or perhaps secrete metabolites that shield the kidneys from crystallization while leaving the bone matrix vulnerable? It is virtually uncharted territory of systemic biology that could finally explain the seemingly random, shape-shifting nature of this disease.
It is a perfect reminder of how integrated the human machine truly is. We have covered an immense expanse of clinical and biological territory today. Let's synthesize the journey. We began by identifying the silent thief, the mechanically broken, dusty calcium thermostat that defines primary hyperparathyroidism. We tracked the historical evolution of the disease, watching it transform from the agonizing, visible skeletal deformities of the 1930s into the highly complex, stealthy, asymptomatic biochemical presentations discovered by modern autoanalyzers.
We detailed the rigorous, methodical detective work required for an accurate diagnosis, exploring the vital necessity of mathematically correcting for albumin protein variations and utilizing advanced urinary analysis to rule out genetic mimics like familial hypercalcemia. We navigated the contentious clinical debates surrounding neurocognitive symptoms like brain fog, establishing why the strict application of evidence-based medicine and randomized controlled trials must guide surgical interventions to protect patients from unwarranted risks.
We outlined the definitive, data-driven surgical tipping points, the specific thresholds for blood calcium, bone density degradation, and renal scarring that dictate when intervention is absolutely necessary. And we unpack the brilliant, seemingly contradictory paradoxes of medical management, from utilizing calcimetics like cinacalcet to allosterically trick the mutated receptors, to understanding why maintaining adequate dietary calcium is essential to prevent the catastrophic biological panic of secondary hyperparathyroidism.
Ultimately, the fundamental value of examining this specific clinical guideline isn't solely about memorizing the parameters of an endocrine disorder. It is about illuminating the hidden, breathtakingly complex and tightly regulated networks operating silently inside your body at this very moment. The delicate, constant interplay between dietary minerals, active vitamins, the structural integrity of your skeleton, and the microscopic sensors on glands the size of rice grains.
That is exactly the point. Gaining this biological literacy empowers you. The next time you undergo routine lab work and you see the word calcium printed on the report, it will no longer just be an arbitrary number on a page. You now understand the intricate, relentless biological ballet required to maintain that number within its safe parameters. You understand the implications if that number deviates. You are equipped to ask your physician-informed, precise questions. You transition into an active, knowledgeable participant in your own systemic healthcare.
Which brings us to a final compelling perspective. The entire history of our understanding of primary hyperparathyroidism is fundamentally a history of our technological ability to observe the human body. Consider how the entire clinical presentation of this disease shifted overnight, simply because engineers invented an automated blood chemistry analyzer in the 1970s. We transitioned from treating agonizing, end-stage bone deformities to intercepting tiny subclinical molecular imbalances in individuals who felt completely, perfectly healthy.
It was the equivalent of suddenly turning on a high-powered floodlight in a pitch-black room. We saw exactly what was already there.
It forces you to ponder a provocative reality. As our diagnostic technologies inevitably continue to leap forward over the next decade with the integration of artificial intelligence pattern recognition, advanced proteomics analyzing thousands of proteins simultaneously, and ultra-high-resolution metabolic imaging, what other massive, silent physiological imbalances are currently occurring right now in your body, just waiting for the right technological lens to be invented so we can finally see them?
That is exactly the kind of question that keeps you up at night, wondering what else is hiding in the murkiness. Until next time, keep diving deep.